Hi, and welcome to the Physician-Audiology team, a cochlear implant model. I'm Camille Dunn, the director of the Cochlear Implant Program at the University of Iowa.
And my name is Jay Gantz. I'm the current neurotology fellow at the University of Iowa.
Here is my bio and my presenter disclosures.
This is my bio, and I have no disclosures to make. So the goals of this presentation, we wanted to share with everybody the model of what we do here at the University of Iowa and present kind of one idea for how to present and deliver cochlear implant care, specifically looking at the interplay between the physician on the team and the cochlear implant audiologist, and put that in the context of all the different people who are involved in delivering what we consider to be high quality cochlear implant care. And then we just wanted to give a couple examples where we think these particular patient situations highlight where the audiologist and the physician and the rest of the cochlear implant team models can really strengthen the team and how they do that specifically. So the context of hearing care is really important. For us, we look at a patient who comes in with hearing loss as having this hearing loss impact so many different areas of their life. This involves everything from their cognitive function to affecting their job, how they get along with their family or in other social situations, possible social isolation. None of these things are unfamiliar for hearing health professionals, but I think it's important just to bring up the idea that when we see a patient and are thinking about their hearing, this impacts a lot more just than what their ears look like on physical exam and what their audiogram is. So when we think about the cochlear implant team, this is a lot more than the audiologist and the cochlear implant physician. You can see here the list ranges all the way from the primary care provider, various different levels of medical providers, ENT physicians that might be specialized in otology and be very familiar with providing cochlear implant care, all the way to somebody who is just the general local ENT who has an idea and a basic understanding, but doesn't necessarily provide that care in their clinic. Furthermore, there's a lot of people in the team like vestibular therapists, speech language pathologists, psychologists who play a big role in making cochlear implants a success for a patient. And then even somebody like an educator, especially for younger children or people with individualized education plans, who really help make this work. And we'll kind of highlight that a little bit later in a particular example. So I think one of the first things to talk about when we look at the audiologist-physician relationship are expectations in both directions. So as a physician, what do I expect from the audiologist team members? And I think it's fairly straightforward. It's expertise and understanding the different technology options that are available, empathy, basic delivery of high quality care and compassionate care, and being able to have an effective patient care model where the communication with all team members is really important and highlighted and demonstrated to the patient.
So when we look at an audiologist, obviously there are expectations for the physician as well. And when we highlight those, they're identical. You know, I think the audiologist and the physician have these three goals in mind when they're providing quality patient care. So the keys to a successful collaboration, when we took a step back and we're thinking about this, both Dr. Gantz and I, work in the same tertiary care facility. We work in a hospital, so our proximity is very close, but that's not always the case for every physician audiologist collaboration. And so I think when we tried to think about the success of a collaboration, we had to kind of think outside of the immediate setup that we have here at our hospital. And I think one of the first things you really need to think about is, what is the scope of the practice? What that goes both ways. From, is it a general ENT clinic? Is it a busy neurotology clinic? And then let's take a step back and think about the audiologist clinic as well. In our facility, we have very defined areas of audiology practice. We have a cochlear implant area, we have a diagnostic area, and a hearing aid center. And while each of those are placed in the same department, on the same floor, in the same area of the hospital, each of us really are independent. And so I think understanding the scope of practice, are you an audiologist that is seeing a hearing aid patient, vestibular patient, audiology, cochlear implants, and what is the scope of the audiology practice? And that's going to translate right into the nature of your relationship with that ENT, especially in referral types of resource availability. So when we talk about provider availability, how prompt are the appointments? I can tell you, over the last year, our cochlear implant appointments are getting pushed out further and further, just because we have a really high rise of patients that are being referred in. The patients are coming in for cochlear implant evaluations. The patients are coming in for follow-up care that maybe during the last 18 months, where we have had COVID halts for medical care and some other things. All of that stuff is kind of getting caught up right now. And so the promptness of appointments is something that you're going to want to think about. The insurance landscape, are you a care facility that provides private Medicare and Medicaid insurance? Obviously, that's going to be something that the physician is going to want to think about if they refer somebody to your audiology clinic that has Medicaid. And here in Iowa, we don't have very many hearing aid centers throughout the state that provide hearing aid types of care for patients that are Medicaid. Those are certainly some specific types of insurance that you would need to think about. Also, what are the out-of-pocket costs, the cost structure? Does your facility or your hospital have payment plans? And also, do they have access to charity programs for those patients that really need patient care and a cochlear implant or some type of hearing assistive devices, but maybe they don't have the financial backing to be able to have access to that type of care at this time. And so having access to charity programs, or knowing how to reach out to them and enable these patients to continue to have hearing health care is really important. Certainly customer service. This is a service industry. And so being able to, this goes back to empathize with your patients, to understand that this is a difficult time for them. They call, they have troubleshooting issues, they have medical issues. And so being able to provide that patient with an understanding of what the next steps are, how you can help them achieve their goals for their hearing healthcare, I think is really important. And certainly a clinic accessibility. When it goes back and forth from the audiology clinic to the ENT or neurotology clinic, is it accessible? We have a lot of patients that come in that are maybe elderly, or parents that have small children, and being able to walk into the clinic and park and have access to the different appointments is very important. And so these are all things that I think, if you're going to establish a collaboration between the physician and an audiology clinic, that are really a priority for you to address and talk about between the physician and the audiologist.
And before we move on, I just want to capitalize on or say a couple things. Particularly with cochlear implants and the insurance landscape, private Medicare, Medicaid, this is a huge deal in terms of what types of implants are covered, because the indications can vary based on the payer, the insurance provider. Certain private insurances have different levels of support for cochlear implants, particularly in situations such as like single-sided deafness. And I think that's a really important consideration to understand together as an audiologist and a physician team when you're presenting options, discussing options outside of direct discussions with the patient, and coming up with a unified front as a whole team to understand this landscape. So, in terms of best practices and how we deliver this care, our goals are the same as we've discussed. We really want to meet the patient at their level of need. We want to deliver high quality, privacy focused care, maintaining all HIPAA practices, communicating as effectively as possible with the patient's care and goals in mind when we're discussing things with our audiology team. You need to focus on the needs of the practice. You need to define what your practice provides and present that in a cohesive way, in an understandable way to all different types of patients who walk in the door, while maintaining your commitment to why they walked in the door in the first place. They need some help with their hearing, and that's what we're here to provide. Moving on, in terms of expectations, similar to what we talked about earlier in the relationship, the physician expects the audiology team to be the experts, to be available. And I think this is really important, something that we try to practice as much as we preach here at this center of we're lucky enough to be in physical proximity between the physician's clinic and the audiology clinic. And quite frequently, we walk back and forth and discuss patients in real time. And we understand that the other side of the team isn't always going to come at the most convenient time, but we'll do our best to be available, step away from what we're doing and discuss that patient. And I think that that's a two-way street that makes a lot of sense and gives our patients the best care. We expect the audiology team to provide a thorough analysis of all the dimensions that we can measure to help us get a better understanding both of what the patient's doing today and how they're doing today with respect to how they've done in the past. And then it's our job to support, or it's our expectation to have the audiology team provide device support. This comes into the frequent communications from the device companies that have to do with upgrades or device malfunction in terms of things that external processors that might need to be replaced or components that need to be replaced. And then kind of the main piece that the physicians expect the audiology team to do is to help diagnose and treat and recommend the technology. We have, as physicians, some level of expertise to understand the technology and understand who it's most appropriate in, but at the same time, we're not doing these objective measures, and we're not directly interfacing with the devices in a customer service way in the same way as an audiology team does. So we really expect and hope that the audiology team brings that to the table.
And likewise, with an audiologist, there are certainly some expectations for the physician, and no surprise, we want the physician to be the expert when it comes to the medical care for the patient. We want to be able to provide them with the analysis, the word recognition scores, the thresholds, and all of those other tests that Dr. Gantz spoke about. And we expect that, they're going to be able to take that information and help us decide on the best technological recommendation for that patient, whether that would be a BAHA, bone anchored type hearing, or osseointegrated type device, a cochlear implant. Maybe that patient should just stick with a hearing aid because they haven't consistently been using hearing aids. And so we want to make sure that that patient is willing to try different types of technology to help their hearing. But likewise, sometimes we have patients who aren't wearing hearing aids because of the nature of their hearing loss. And so, we talk amongst ourselves, like Dr. Gantz said, a lot of times in real time. We'll go over to the clinic and inform the physician of their upcoming cochlear implant evaluation that day. We'll talk to them about the medical history and their outcomes with some of the speech perception testing, and kind of give them an idea about where we think we're going with that patient, whether we do think they're a good cochlear implant candidate or if we don't think they're a good cochlear implant candidate. And then we talk amongst ourselves to develop a plan so that the audiologist can go back and kind of give that patient an idea where they're going and what their next steps are going to be. I think the other thing is we expect the physician to be available. We know our physicians are super busy, and they have really dynamic days where some days they're in clinic and then they jump over into the OR and then they have some office time. But our physicians always have the availabilities of paging them. If they're not available to answer a page, they provide ways for us to really know that they're in touch with our needs and making sure that the end goal, which is patient care, is achieved.
So in terms of what we expect in terms of how to inform the team with our level of expertise from a physician standpoint, is we need to talk about the practical limitations of any intervention with respect to the patient's health status. You know, if a patient really needs a cochlear implant, but they are unable to withstand a surgery, for example, then we need to think about other options. Or if they have a particular type of medical comorbidity that makes one type of bone-anchored hearing aid preferable to another, or something like that, that's what we can bring to the table. And then, of course, it's very important for us to manage and identify unexpected complications from any device, whether that's an infection or an extrusion or a need for an explant reimplant in the case of a device failure or something like that. You know, that's very critical for the physician to fill that role on the team.
And Dr. Gantz presented a whole host of people that are on a team, and some of those include like your primary care physician, they include a psychologist, they include a lot of people that might not know exactly how to read an audiogram. And so I think for us, it's important for us not to give somebody a piece of paper and expect that they're going to be able to look at it and understand exactly where we're going with that conversation. So we need to step back and make sure that if that expert, that physician, doesn't necessarily have an expertise with an audiogram, that we take a step back and help them understand what we're seeing on the audiogram, what the limitations are, and talk to that physician about the referral that they may have given us for a cochlear implant. And maybe we look at the audiogram and understand, yeah, they're not a good cochlear implant candidate. They have 86% word rec in each ear. Their hearing loss across the board is moderate, doesn't even dip into the severe. A hearing aid trial might be a much better type of technology for that patient rather than a cochlear implant. So I think for us to develop that inner team education is making sure that when we all talk about patient care, that we're all on the same page. And sometimes that takes us a step back to make sure everybody understands the language that we may be talking in, and we're all on above board on what the best type of rehabilitation might be for that patient.
So to kind of illustrate what we're talking about here, we first want to discuss some candidacy considerations, but then we want to give a couple patient examples that kind of illustrate what we've been talking about so far.
Okay, so first we're going to talk about candidacy considerations. When we think about cochlear implants, candidacy has certainly changed. The earliest patients were getting cochlear implants was in the early 1980s. And since that time, candidacy has changed. We now understand that age at implantation, duration of deafness, amount of residual hearing in the ear that we're going to implant all make a difference. When patients were first considered a cochlear implant candidate, we initially thought, hey, if the patient doesn't have hearing, then they're a cochlear implant candidate. If they can't talk on the phone, we didn't really appreciate in the early 80s that all of these things, age at implantation, how long they've had deafness, is going to matter when it comes to outcomes. And then along with that, our test metrics. for cochlear implant evaluation have changed. We don't just look at an audiogram and assume that based on, like I said, in the early 80s, that they're not going to have any word understanding. Now patients definitely have word understanding. And some of the old tests that we used to use are not appropriate anymore because patients get ceiling effects. And ceiling effects are when scores are high and we're not able to see improvement. And so we want to make sure that our testing metrics provide us with scores that we can measure benefit with the cochlear implant after they receive the cochlear implant. And so now we're using CNC words and we're using AZ Bio sentences in quiet and noise. That's part of the minimum audible test battery for the audiology cochlear implant field. And then we also want to look at subjective ratings. So we go beyond looking at what a laboratory test does and ask that patient to help us understand how they judge their hearing in certain environments based on retrospective questionnaires. And then we also follow that over time to make sure in those same listening conditions, in those same listening situations, the patient feels they're improving. The other thing that is really important to be on par with your physician and audiologist is the interpretation of insurance guidelines. CMS or Medicare says that you need to have best aided connected speech scores. They don't talk about whether those speech scores are presented in noise, whether they're what loudness level they're presented at. It doesn't say what best aided is. All it really says is they want connected speech or sentence scores that meet a certain criteria. And so I think for a physician and audiologist to be able to be on the same page and understand how you want to interpret those guidelines to provide the best patient care. And I think as cochlear implant candidacy has shifted over the past few years, so has the interpretation of those insurance guidelines. And so I think our first case study is going to kind of talk you through how a physician and an audiologist need to be on the same page when they're providing a recommendation for a cochlear implant. So this first patient is a 78-year-old adult male. He had an audio confirmed for bilateral moderate to profound sensory neural hearing loss. He was seen in our clinic and for a hearing test, and then was sent over and to visit with Dr. Gantz to discuss his hearing and if there was anything he could do to help it.
So just like Dr. Dunn said, we have some objective information when we first see the patient, but it's our goal to elicit a full and complete hearing and medical history. So we understand that this patient has been wearing bilateral hearing aids for about 10 years. They do have a significant history of noise exposure, both from their work and from their hobby. They don't have any family history that is suggestive of a genetic process. And this patient did suffer a stroke 5 years ago. But it doesn't seem like anything that we're talking with about them is their stroke changed their hearing in any significant way. But we need to understand that, have an idea of whether or not there was a temporal relationship between the hearing change and the stroke, and understand hopefully where that stroke was and any residual symptoms they might have. And then it's our goal in our visit to discuss with them, like, what are their goals? Where are they struggling? And so for this patient, they're having a difficulty understanding their family, their children and grandchildren. As I mentioned, they're living with these people. And the hearing difficulty has created family tension. If this patient often can't hear when grandparent or grandkids are talking to them, that makes it very difficult and challenging between the patient and certainly the child's parents and the children themselves. And it makes them feel isolated in this environment. And those are, trying to tease out the root causes of what we can do to improve their life. So like we said, the evaluation that we're doing is doing this thorough hearing history, asking about the goals, looking for modifiable causes of hearing loss. This is really structural things that we can address if they have a modifiable conductive hearing loss that we might be able to address before considering something like a cochlear implant, whether or not it's appropriate for them to undergo something like a cochlear implant in the face of different structural causes of middle ear disease, for example. We talked about getting the objective exams performed by our audiology department. And then it's our goal to discuss the results of this. After having discussed with the audiology team, like Dr. Dunn explained, our goal here is really to come as a unified front to discuss the context with what we've just learned from the patient with the discussion that we've had with the audiology team. And so for this particular patient, we discussed the broad differential and possible other causes of hearing loss, but likely that, a cochlear implant does make sense. And so it's our job then to say, let's do the more specific testing that's specific for cochlear implant candidacy criteria, submitting that for insurance approval. And then we always do imaging prior to cochlear implantation, and we prefer MRI as part of that medical workup. So we'll often say at the end of our visit, let's schedule an MRI and have you do the cochlear implant evaluation and discuss those results at our next visit.
So then the patient is referred, and our patient care coordinator for the cochlear implant team is informed that there's a patient that Dr. Gantz saw in his clinic today that, possibly is interested in a cochlear implant. So when we bring that patient in, we kind of tee up, look back at the history that Dr. Gantz obtained today to try to understand the family history, the family dynamics that's going on with this patient, some of the medical history that he's had in the past. The first step, we don't need a new hearing test because he just had one, which brought him in to see Dr. Gantz in the first place. So we don't repeat that, but we do want to make sure that the hearing aids that the patient is wearing are verified. And if the patient comes in and those hearing aids are not appropriately fit for him, then we have loaner hearing aids in our department that we're going to fit him with for the remainder of the cochlear implant evaluation. At this point, we kind of have it set up so that our cochlear implant audiologist can verify the hearing aid fitting, or we can send the patient down to our hearing aid center. A lot of times our patients are coming in and they receive their hearing aids through our hearing aid center. So it's just as easy, since they receive their care there, to send them there to get their hearing aids verified. Or again, if the hearing aid center is booked up for that day, we don't want the patient to have to wait for availability in the hearing aid center. So our cochlear implant audiologist will verify those devices. And for this patient, his hearing aids are actually severely underfit for the degree of his hearing loss. And the patient reports he has not seen his hearing aid audiologist for about the past 4 years. So we do fit him with loaner hearing aids for the cochlear implant evaluation, but we're able to take his ear molds, utilize them for the hearing aid evaluation. We don't have to put the temporary molds in. We change his tubing, make sure that that is all up to par on his personal hearing aids, and the patient immediately reports, wow, those are loud. That sounds really loud to me. And so from that, a lot of times our patients haven't been in, like I said, in 4 years, and so their hearing has maybe changed. Or some patients convince their audiologist that they don't want their hearing aids that loud, and sometimes we're in a position as a hearing aid audiologist where we have to turn down the amplification of a hearing aid just to get that patient to wear it. But nonetheless, we want to make sure that when we're filling out our cochlear implant evaluation, that his hearing aids are fit at the appropriate level, that we're meeting targets if we're able to do that. So the cochlear implant audiologist is now filled on the hearing aid situation. That patient now is going to get ready for his evaluation. So the patient and his daughter, he lives with his daughter and his grandchildren. His wife is deceased, and that's been pretty trying on the patient. We review his hearing history, and all of the things in this little spider diagram kind of talk about all the things that we consider when we want to understand if this patient's a really good cochlear implant candidate. So again, it used to be we'd look at the audiogram, most patients didn't have speech understanding or speech recognition scores, but that has changed. And so we want to get a little bit more hearing history. We have the patient fill out a static form, which talks about what his expectations are for the cochlear implant. What, maybe, his daughter's there and we start discussing it. Maybe she talks to us a little bit about what she hopes her dad will be able to achieve with the cochlear implant. We talk about his lifestyle. How much does he go out? He reported to Dr. Gantz that he feels pretty socially isolated, but what are his goals? And does he want to be able to go out, enjoy coffee or visit easier with his friends? And the patient does say that those are some of his goals. So that gives us an idea where he wants to go. And we were able to talk to the patient to say, here's the areas that we think the cochlear implant are going to help you. Yeah, I think it is going to be better when you're talking one-on-one with your grandkids. That doesn't mean that your grandkids can start walking out of the room and continue talking to you, and you're going to be able to hear them and understand. They still need to understand that we need to look at grandpa front on and be able to discuss and have conversations with him. Is it possible for you to be able to go out and have coffee with your friends? Absolutely. But there are some listening accessories that we think may be helpful to you after you get your cochlear implant, that you may be able to use in that situation to help you have an easier visit with your friends and family. So we talked to that patient about those things right up front, because we think it's important for that patient to go into the cochlear implant with appropriate expectations. We know his goals, but then we want to set him up with our goals. So these are our goals for you, the patient, and what they want to hear. We complete our testing. We do both CNC words, which are, again, something that our team has talked about and decided as a CI team that CNC words really provide a valuable way of testing the patient's speech understanding. It doesn't have the maybe cognitive processing or all the other variables that go into when you're understanding a sentence, which involves a lot of cognitive processing, executive functioning, and some of those things if sentences are particularly long and if sentences are presented in backgrounds of noise. So we really look at CNC words because at any cognitive level, patients are going to be able to repeat a word back that they heard. And it gives us a good understanding of exactly what their word understanding is without those other variables. But because insurance requires us to have connected speech, we always want to test in that connected speech listening environment, and we put them in a +10 because that is realistic, right? We run around and talk and are in noisy environments, and that particular is where the patient wants to be. He wants to be able to be in an environment where he can visit if there is background noise. For this patient, he has a little bit of asymmetry between his ears, 55% words in the right ear, the left ear was 34, and bilaterally he got 57%. When we look at his AZ-Bio sentences in a +10, again, the asymmetry showed up in that testing paradigm where the left ear was the poor ear. Now the patient has 41% bilaterally, and this is where we need to think, is this patient a candidate at this point? And so do we continue with the evaluation? Is the patient a candidate so far? So this is where it's really important for that physician audiologist to be on the same page when it comes to CMS guidelines. Their guidelines specifically say bilateral pre or post-linguistic sensory neural moderate to profound hearing loss. The patient has bilateral moderate to profound hearing loss. He fits that. The patient demonstrated limited benefit with amplification by test scores of 40% or under in the best aided listening condition. So did the patient meet that? Well, we know his connected speech scores. He had 41% in the right ear and bilaterally. But in his left ear, or the ear we would want to implant, he scored much poorer. And so we as a group need to decide, first of all, what are you going to consider best aided? For our center, we used to consider best aided anything when they have both their hearing aids on, so their bilateral score. But as we started looking at this, we said, you know, we're not implanting both ears. We're implanting one ear. So let's look at the best aided condition for that ear we want to implant. And so as a group, that's what we've come to. And this patient met that criteria. I believe if I go back, he had 23% in that ear we wanted to implant. So for us, we consider that patient a candidate for a cochlear implant from an audiologic perspective. So we feel like he demonstrated limited benefit in that with that amplification in the ear we're going to implant. So here we have patient A going on. So we finish his testing. We walk over, as Dr. Gantz said earlier, we do a lot of our discussions in real time. Our patients are here all morning. Our cochlear implant evaluations involve, you know, they come at 8:30 and they typically are done about 1. And so at this point, we have the testing done. We've talked to the patient about their expectations, their hearing history. So now we're going to go over to Dr. Gantz in his clinic and say, hey, you have this patient coming in. You saw him previously. You referred him for a cochlear implant evaluation. And I think that's a great idea. Here's what our testing shows today. And so now the surgeon and I are going to discuss what we think the best next step is for that patient. Because this patient has a sloping hearing loss, we feel that hearing preservation may be beneficial to this patient. And because this patient has, you know, decent word scores, 23%, he's definitely not bottoming out. And we want to be able to work with what he already has in that ear and to provide him with the best outcomes post-operatively. So the surgeon and the audiologist will kind of discuss what we think the best internal device choice is for that patient. And then the audiologist will go back and visit with that patient based on the conversation. And we always tell them, you know, we went over and discussed this with your surgeon. This is kind of what we're thinking, but Dr. Gantz will fill you in on that more when he sees you in just a few minutes. So the patient heads on over and is now going to meet with the physician.
So I think exactly what Dr. Dunn was just explaining, that's where the magic happens, is that real-time discussion with the audiology team while the patient is in clinic and while we can have this discussion in real time. Very helpful to have references back to our previous appointments and what we discussed and why we referred this patient for a CI eval. And then discussing the potential of which device is appropriate. And we're not trying to be prescriptive here of saying, thanks for coming in your interest in a CI, we're going to put in this particular device, but it's, you know, these are the goals that we think we could best match with a device like this. Does this make sense from your end? And we try to rely on the audiology team to explain to the patient the benefits of one device over another, why one device might be more appropriate or give them certain advantages that you can't fulfill with every device that's out there, and then discuss that. And that's really kind of coming at it as a unified team to give that recommendation so the patient isn't confused if somebody says something and somebody else says something else later. The idea is to have that discussion in real time. So then it's our goal when we see the patient to fill them in on this discussion that we had with the audiologist, answer the questions that they might have residual from their audiology visit, and discuss the surgery. With most cochlear implant surgeries, this is relatively straightforward. It's an outpatient procedure. Tell them what we're going to do and why, what to expect, possible complications, and then fill out the consent form and have our nursing staff do the full pre-op assessment. You know, in medically complicated cases that could involve referrals for surgical co-management with people from general internal medicine, for example, or it can be very straightforward. So, you know, that at the end of that visit, at the end of this portion of of their whole CI workup and eval, this is where we're saying, should we go forward or not? And are you interested? And sometimes the patient says, great, I've gotten all this information. I'll sign the consent today, but let's not schedule the surgery yet. I'll give you a call back after I've talked this over with my family. And some people are rearing to go and want to be on the schedule as soon as they can. And we try to address those needs as best we can. So in the background, of course, oftentimes it's really important to get insurance approval before proceeding with surgery. Certainly in cases where we might be trying to do something like single-sided deafness or something like that, that's a more payer-sensitive green light to go ahead with something like this. So we say to the patient, let's schedule the surgery as best we can. We'll talk to your insurance company and we'll let you know as soon as we know about the approval process. And of course, unfortunately, we don't have a defined timeline, but we say in a matter of a week to a month to sometimes longer, we'll go back and forth. And if we get a denial from the insurance company, we'll fight that as a CI team, writing letters, trying to support our justification for saying that this patient would benefit from this procedure, and providing all the objective data that we can to support that. And I think that process is something that the whole CI team has to be on board with, and you can definitely develop a routine that makes it, it's still onerous, but if you do it more frequently enough, that the team isn't caught off guard by having to do this extra work.
So finally, with this patient, the surgery occurs, and the surgeon comes down and kind of fills in our audiology team, which is something we really, really appreciate. The surgeon will come down and talk to us if there were any complications, if there were any insertion issues. And this is really important because, while we're going to go in and read the surgery note and everything that happened, it kind of gives us a heads up of what to expect at that cochlear implant activation. And again, going back and having that one-on-one communication with the surgeon in real time, I think provides the best care for that patient.
And of course, we are trying to provide the most streamlined form of care we can for this patient. So we prefer closures that don't necessitate suture removal, and give patients an idea of what to expect when they leave in terms of the healing process. And the next time they're going to present to the hospital is for their activation appointment, usually about 3 weeks after their surgery.
Yeah, and the audiologist at that time, we don't typically always schedule the patient to come back and see the physician at the activation. But I think Dr. Gantz can kind of echo this. Maybe, he relies on us to be able to assess that surgery site, to be able to look and make sure that there is no redness, there's no breaking down of the skin before we want to do that activation. We're typically doing activations about 2 weeks post-surgery, and so making sure that that site looks healthy before we do that activation is really important. So that kind of sums up what we were going to do today. Dr. Gantz and I are, really excited about the topic of being able to explain how the physician and the audiologist and the whole cochlear implant team really work together to provide the best holistic patient care. I have to tell you that I'm sorry we are not able to be in Naples, Florida in November. I think it would be a beautiful time to be in Florida, but rather due to the COVID restrictions we have here at the hospital, we have to stay in Iowa City. I know that probably makes a lot of you jealous that you can't be here in Iowa City, but we appreciate you taking the time listening to our talk. If you have any questions or concerns, please don't hesitate to reach out to us.
Thank you, everybody.
Hello, and welcome to Radiology for Audiology and Advanced Practice Provider. I'm Mark Wydick. I am an otologist and otolaryngologist in Boca Raton, Florida. It's a pleasure to be here today and in the virtual world to present a topic that I don't really think has been presented before. I did my training at Vanderbilt, my fellowship and residency, and have been practicing otology and neurotology in Boca Raton since 1994 after leaving Vanderbilt. I have been past president of the Florida Society of Otolaryngology, and it's a pleasure to be starting this lecture series in advanced practice providers and audiologists, trying to bring us all together a little bit better so we understand what we're doing. So I will be presenting the otology portion of it, and my colleague, Amy Holyfield, who I'm introducing right now. Amy, would you introduce yourself and say a little bit?
Hi there. My name is Amy Holyfield. I'm an audiologist. I've been in practice for almost 25 years now. I've worked in a combination of private practice, hospital-based, but I've been in ENT since 2003. And I graduated from University of Florida. I went to graduate school at University of South Florida and got my doctoral degree through A.T. Still University at Arizona School of Health Sciences. I have been working with a combination of pediatric and adult patients with cochlear implants, middle ear implants, bone conduction devices, vestibular disorders, hearing aids, and all, like I said, primarily in ENT setting for the last, since 2003, the last 18 years. And I'm excited to be with you all today. This is something that is a topic that I find very interesting, and I hope you all will as well.
So I and Amy have nothing to disclose regarding conflicts of interest, so feel free to pay full attention. We won't be biased by any financial issues that would prevent us from giving the truth and nothing but the truth. So the outline today in this lecture, we're going to try and serve an introduction to what I feel and Amy feels are important topics that maybe are not covered as well as you would want in your training or in your experience. So just spend a little bit of time combining audiology and radiology so that we could really do a few case presentations after explaining the different modalities that are available, and hopefully at the end take your questions or at least to give you a little bit of insight as to the differences between radiology involving standard CAT scan and the MRI, and which study is most important given the clinical situation. There's very clear-cut indications for one or the other, and sometimes both, but often one or the other is more than adequate because they look at things very differently. There are different disease processes that I would be concerned about and then would order one study over the other because I know it's going to give me the most information about the particular pathologic process that I am concerned about. So with that, we're going to present some cases and go over the modalities of the CAT scan and the MRI scan, how they're similar and how they're different. One of the things that has been very, very helpful to me in private practice was the advent of the little mini CT scan. And I would say since 2014, when we bought one of the very first units, which is still operating just fine after many, many servicings by the company, but it's well over 15 years, still gives us excellent images is quite a value, both in that it's small, it can go into it could really fit in just an exam room and doesn't take a whole lot of like high-powered energy. You just plug it into the wall. There is some certifications that are required in inspections for radiation compliance, but all in all, it's almost a plug-and-play device that we've been using continuously. The style of scanner in this image is exactly the unit that we purchased, 15, 16 years ago. And we now have some new units because we have multiple offices, and I don't think any of the offices could possibly function without it, because it gives us the ability to look at the ears, CAT scans, just as detailed as almost any other study, with a few caveats. And it's just a fantastic tool to help us diagnose patients and really get a complete evaluation in one office visit. And maybe, Amy, I'd ask you to comment on how you feel the flow of patients in audiology and scanning and radiology occur in the office.
It's pretty seamless because they're scheduled in such a way that they can go from one appointment to the other. And even if you have to work them in kind of on the fly, it's kind of the same. The working a patient in with CT is kind of the same as working them in with audiology. It's pretty easy.
Right. The CT scan, to have a patient schedule one, leave the office, go get it done. It's another visit. They have to go to the scan unit, wherever that might be, and then come back, have us review it. Instead, it literally is a 5-minute. They walk down the hall, sit down. The technician is able to input the information about the patient, hit the scan button, and the scan takes maybe 15, 20 seconds. And the patient's done. I can come over, take a look at the images. The patient is chomped off to audiology if they haven't already had that done. And then I can present everything that we found all in one visit. So it's really great value for everybody concerned. The other study that is unfortunately still requires a visit and to leave. So it's 2 visits to us and 1 visit to the radiology center, is the MRI scan. And that's just because it's a much more significant piece of equipment. Instead of, in the thousands of dollars, or at least tens of thousands of dollars for a CT scan, the MRI scan is in the order of millions of dollars, and takes a large specialized room. Most people are probably familiar with an MRI at one point or another, either them or a loved one. But it's a large machine. It's claustrophobic for many people, sometimes even requiring general anesthesia for patients who suffer from claustrophobia to get through. So it's certainly not nearly as convenient. And if you have a preference of one over the other, just from convenience, then the CAT scan is hands down the better study. But they do look at very different things: the soft tissue, the nerve, vascular structures, also some biologic properties are best done with the CAT scanner. But when it comes to other details, then the CT scan can win out. When it's essentially the bony structures, air-containing spaces like the sinuses or the mastoid, and the mucous membranes of those structures, then the CT scan can do a perfectly adequate job. I'm going to try to click. We've got some links here to normal studies, and we'll see if this comes up okay. I don't think we're centered. Let's see. Okay, so this is a CT scan of the temporal bone, and we will typically get them in at least 2 axes. This is not contrasted axial image, and this is a coronal image. And this is a very good study. You can see all sorts of detail. In the coronal study, I'll look for a variety of structures. We've got the head of the malleus in the body of the incus. This whole area here is the middle ear space. This is the external auditory canal. This is the top of the patient's head, and this is down towards his toes. And I can scroll through these images. So I'm starting anteriorly. Here's the jaw joint. And then I'll just go posteriorly and I'll point out some structures. This is the carotid artery. This is the eustachian tube. And as we go further, you start to come in from the eustachian tube. You can see that it travels right into the middle ear, becomes the middle ear space. And then we've got the ossicles, the different tendons and muscular structures that attach. Here we have the tensor tympani, which attaches. It's a tendon that goes to a muscle, and it's part of the acoustic reflex system. And then you can see the incus come into the stapes bone, which is this right here. You can almost see right there the arch circling around of the stapes bone. Or the capitulum is the other part that we talked, the top of it. And then the foot plate would be in this region here. And then this spiral structure right here is the cochlea. And one of the things that's easy to see is the facial nerve. And it's easy to remember. You talk about the eyes on the snail. So here's the cochlea, and here are the eyes. 1, 2, and you see the facial nerve in 2 positions because of the way it exits the skull. It comes out this channel, and then it comes right up here, this beautiful detail. And then it has the longest course of any nerve through the bone. And you can see as I scroll further, it looks like 2 eyes. And then we come back and it goes out to the brain here and travels through the ear under the horizontal semicircular canal, which then descends to the stylomastoid foramen and then heads out to the face. So that's the structure, the facial nerve, and its anatomic relationships to the ear. That's one of the very basic landmarks in ear surgery. 1, because you never want to hurt it, and 2, is it helps you know where you are while you're doing a variety of otologic procedures. Other things that I'm always looking at is that there's air in these structures. Air is black on a CAT scan, and then this is the mastoid, which is a large air-containing sinus behind the ear canal. And here you can see the soft tissues of the ear on the study. So just to kind of help orient you where we are. This is the dividing line between the temporal bone and the brain structures, or the temporal lobe above. And you can see in this ear, and it's very common, that there are some areas where it's extremely thin or even absent the bone that separates your brain from the ear. It's one of the reasons that at least you need to be concerned if somebody shows up with a high fever and a draining ear and altered mental status, because meningitis gets its access to the brain through these thin areas that you can see so easily between the mastoid and the temporal lobe above. In this area, there's really probably nothing but just dura. And when we're doing surgery in the mastoid, we often open this up and we're looking in here, and you could take instrument and palpate up here, and you'll see that this is just soft, that there's no bone, there's no separation between the ear and the meninges, or the dura of the brain, and that's where meningitis could get started. So one of the feared complications, especially prior to the antibiotic age, was ear infections and death because of meningitis. So I will show you the similar images here on the axial images, but instead of going anterior posteriorly, we're going from superior. Now we're up in the brain and scrolling down. This is one of the balance canals. This is the superior canal. And we come down and you can see the horizontal canal. Again, the cochlea, but in a different orientation. And the malleus and incus, it's easy to remember because it looks like an ice cream cone. You got the ice cream and the cone. So the ice cream is the malleus and the cone is the incus. So it's something that's kind of fun to remember, and it shows you a quick way how to figure out where you are. And then as you go a little closer to the toes from the ice cream cone, you're going to have the incus, the malleus, the incus, and the stapes. And there you can see really pretty nicely the arch of the stapes. So this is a very nice CAT scan. There's a reason they picked it for demonstration purposes. And the eyes on the snail here, you could, so imagine we're cutting it the other way vertically, and the facial nerve comes and it has a genu here. This is the anterior genu of the facial nerve. It's also a ganglion here. So there's the geniculate ganglion in this area. It looks like a 7 right there. And the eyes in the snail comes when the imaging is done this other way. It cuts through the nerve twice right there. And here's the cochlea, see? So you can see that just above the cochlea, because of the geniculate ganglion, it looks like an eyes on the snail. Let's see here. I need to go back to my other page. Here we go. Okay, now I'm going to go to the MRI scan and just go over some normal structures like I did with the CAT scan. So you can see the MRI scan looks completely different. And all that fine bone structure that I showed you before is gone. This is just blackness where my cursor is. And it's black because it is bone and air, and calcium does not show up on an MRI scan. And this is all done by chemical signals, mostly from the hydrogen atoms that are either in fat or water. So fatty structures, which are nerves, and soft tissues, or water, are the things that the MRI is able to look at. So this is a really gorgeous study, and you can see that the brain. This is the brainstem, and here's the cerebellum, and that's kind of a gray color because it's mixed content. It's fat. It's mostly lipid, and in this, which is called a T2 image, the fat doesn't show up as much as water, and water is white. It just shows up like crazy on a T2 weighted MRI scan. And so all the structures that are floating in the spinal fluid silhouette out. And so you can see here lovely images right here where the nerve, the 7/8 nerve complex, is leaving the brain at the cerebellopontine angle right here. And all this is fluid, this white stuff, and you're seeing the nerves silhouette. And then they travel out, and here's the cochlea. The cochlea is full of liquid, and the dense hard bone around it creates this very dark signal because it's really hard bone and a lot of calcium, so it just doesn't show up at all. And you can actually see the structures inside the cochlea, again, because they don't illuminate because they're not water. And you can see the horizontal canal right here beautifully. Similar structure. This is right is always over here, left is over here, and you see the corresponding structures here. You go up a little higher, you see some of the other nerves. This is the trigeminal nerve as it leaves. This is the basilar artery. The artery is silhouette out too, because even though they're full of blood, the blood is moving, and that prevents it from showing up as well. So vessels will look like dark lines as the blood flow is moving. And I'll just put up a coronal. Here, let's use that. So this is a coronal, again, just of the ears. So now we've got the imaging plane vertically, and you can see, again, the internal auditory canal and the nervous structures that go in there. There's the vascular supply as well coming this way, and nice images. Let's see here. Oh yeah, here we go. Next slide. So now we're gonna try to go through some case studies, and I've probably gone too slow, but I wanted to definitely point out the structures and make sure that at least there was a little appreciation for what's going on. So we're going to show a variety of case story presentations fairly quickly. What you would expect to find with mastoiditis, similar findings with cholesteatoma, superior canal syndrome, which is an interesting, fairly recent syndrome, maybe a decade or so that's been out and understood, cholesterol granuloma, and acoustic neuroma. So chronic mastoiditis, unlike the image that I showed you earlier, you're going to see inflammatory process in the mastoid. And chronic ear will be the typical scenario. It's pretty rare in adults to have acute mastoiditis or even acute otitis media. And whenever that gets diagnosed, it always puts up a lot of warning flags in my mind that something else is going on. So Amy, I want you to describe this for us.
So what we're looking at here is your basic audiological evaluation, the hearing test. There's middle ear testing in here as well. The graph on the upper right hand side of the screen that has the circles, red circles and blue X's, that is the hearing test. The red circles and red little arrow type symbols, anything in red is going to be the right ear. Anything in blue, the X's and half squares are going to be the left ear. In this particular case, and also on the frequencies are at the top of the graph. So you see the numbers 125, 250, all the way to 8,000. Those are that's the pitch of the sound, and the loudness is on the left side axis of the graph, starting at -10 down to 120. That represents the decibel level of the sound presented, and each of these symbols is plotted at the lowest level where the patient will hear the sound at a consistent response. So this plots the lowest level where they can hear each sound in each ear. Normal hearing is at the upper part of the graph from about the 20 up to -10. Anything below 20 is considered hearing loss, and the greater the hearing loss, the farther down on the graph the symbols will be. So in this particular case, the right ear has a lot of normal hearing. There's some hearing loss in the higher frequencies from about 3, 4, 6, and 8,000. It dips down below the 20 line. And the little arrow symbols that are close to the red circles, the red arrows, that is the bone conduction response. So when an audiology evaluation is done, we're looking to see how the individual can hear when sound has to pass through the ear canal, through the middle ear, and to the inner ear. So the air conduction, which is the circles, is when the sound is presented through headphones or insert earphones, and the sound has to pass through the ear canal, past the eardrum, through the middle ear system, and to the inner ear. Following that, we'll put a bone conduction oscillator behind the ear, and it's generally placed back behind the ear on the mastoid, and we will present those tones again and see if the responses are consistent with the responses from when they had to listen to the sound with the headphone or insert earphone. So in this particular case, the responses are very close. So this would indicate that there isn't really any obstruction, be it in the ear canal or the middle ear space, for sound to get through. When the individual responded, you heard the same way with the headphones and the bone conduction device, which confirms that those responses indicate the sound made it all the way to the inner ear. Now, if you look at the left ear, which is all in blue, you'll see a large gap between the X's and the half squares. So when the sound was presented through the headphone or the insert, and the sound had to go through the ear canal in order to be heard, the sound had to be made much louder than when the sound went with the bone oscillator directly on the mastoid, stimulating the inner ear directly. This individual heard better when the inner ear was stimulated directly than when the sound had to go through the outer and middle ear system to get to the inner ear. So right there with that gap, we can see that there appears to be some sort of obstruction. So then looking down on the lower left side of the graph, there's the tympanogram, the tympanometry. And the tracing, this is the testing that is done for eardrum mobility. The ear canal is pressurized and there's equipment that measures the amount of flexibility of the eardrum. It can tell us if the eardrum is intact, if there's a hole in it, if it has normal mobility, limited mobility. And we look at not only the tracing of the eardrum itself, but also the numbers that you see in the boxes below. When you look at the size of the ear canal volume, the peak pressure, the compliance, all of these things are looked at and it goes in conjunction with the hearing test. In this particular case, the right ear, the eardrum has movement. It has quite a bit of movement. And the left ear, the tracing, you can see instead of the tracing being kind of like coming to a peak, almost like a triangle in that red tracing that you see with the right ear, the left ear is very, very close to the bottom. There doesn't appear to be a lot of movement at all. The movement is very shallow. So that is indicative of potentially an eardrum related, middle ear related issue. And that correlates with the hearing test where we see that you have that gap in response between air conduction and bone conduction. So it's adding support to the obstruction, that there's something obstructing sound from getting through. We also look at the acoustic reflex, which is to the right of the tympanogram section. And that is a series of beeps that stimulates the contraction of the ossicular chain. You heard Dr. Weidick mention the malleus, incus, and stapes, the bones of the middle ear. This test presents a stimulus that causes those bones and muscles to contract, and we can measure the decibel level at which that contraction occurs. In this case, the right ear, when the sound was being presented into, or being measured, I should say, from the right ear, the reflexes, were present at normal levels. When the reflex was measured on the left side, the reflex was absent. We reached a point where you reach the highest level of stimulation and there's no response, no contraction. Again, supporting the tracing that you see for tympanometry and also the results you see on the hearing test above. The other section on this, the audiogram on the testing, the evaluation, is the speech understanding, the word recognition ability. This section, the audiologist repeats words, the patient repeats them back. We lower the volume of our voice until they can no longer correctly repeat the word. And that is represented in the top box that says speech audiometry under SRT. It stands for speech reception threshold, the lowest level where they could correctly repeat the words. We want that level to correlate with the average level of hearing loss in each ear. And in this case, it does. The right ear is about 15. The average level of hearing loss in that right ear, when you measure 500, 1,000, and 2,000, equals 15. And in the left ear, the average of 5, 1,000, and 2,000 for their air conduction response is about 40, 42. And their response here for speech reception threshold was 40. So it's showing good test reliability. And then we present a full list of words at an audible level to see if they can correctly repeat those words back. And we're looking for levels of distortion, for issues that would be indicative of potentially inner ear type of issues, auditory nerve issues. And when you have middle ear type of problems, you will typically see that there is no distortion when they repeat the words back. The audiologist will have to present at a higher listening level so that they can hear the word. But then when they're able to hear it, once they have the audibility of those words, they're able to correctly repeat the words back. And in this case, under the section that says word recognition, this individual scored at 100% in both ears, meaning they correctly repeated 100% of the words correctly. And Dr. Whiting, if I missed anything else, let me know, but I think.
Wonderful job. We do masking if we have to get volumes up at a certain level, and you would have done that, and that's what's indicated there.
And the reason for that would be that if sound exceeds, once sound hits a certain level, the sound will cross over to the better ear through the bone. So you never want the better ear to be the one responding when you're trying to test the poorer ear. So we'll put masking, it's like a static type of sound, into the better ear to distract it so that we can isolate the test ear to make sure we're getting an accurate result of that particular ear.
All right, so I'm going to go on to the imagery that was associated with this or a patient like this. And this right here is the left temporal bone, so the left ear. And you can see that unlike on the right side, which is normal with the, like I showed with the ice cream cone right here, the malleus, the incus, and then the air-containing mastoid and middle ear. On this other side, you can see we're not quite perfectly even. So, but this is the beginning of that ice cream cone. So you know you're in the right place, and we're cutting right through the cochlea here. You can see you don't see the cochlea. So this patient's tilted a little bit, and you can just also tell just by looking up and down that they're angled a little bit in the machine. But you can see fluid in the middle ear, in the mastoid, and even in the ear canal. It looks like there's fluid, and that's a draining ear. So we have a rip-roaring infection here, and there may even be a cholesteatoma, which we're going to talk about in a minute. But in the acute phase, where it's fluid everywhere, you could easily miss a cholesteatoma because on a CAT scan, water and fat density all looks the same. The cholesteatoma is mostly fat. So here is, I was just mentioning that, and here's the word cholesteatoma, and it's found most often in chronically infected ears or children who've had tubes. There's a congenital version of it where somebody may even be born with it, normal appearing eardrum. So in most cases, you're going to find some kind of problem with the tympanic membrane. Either retraction, which is a thin tympanic membrane from eustachian tube dysfunction. That can happen in two different regions, as pars flaccida, which is up in the top part of the tympanic membrane, and we're going to show this in a moment. Pars tensa, which is the majority of the tympanic membrane. You will see some kind of a soft tissue mass. Usually that looks like the material that would be in a whitehead is the easiest way to describe it. It's keratinaceous material. And unfortunately, in the ear where the skin is laid directly onto the bone, the epidermis, there's no true dermis, or it's extremely thin. And so the skin cells can get displaced, and that's what happens. And that's really what happens in a cholesteatoma. It's epithelial cells growing into the mastoid through some kind of defect in the tympanic membrane. So the audiogram would be similar to the one we just showed you, and we'll present the CAT scan here. Here's images taken with really useful cameras. These are cheap cameras you can buy on eBay or Amazon, and they're little endoscopic cameras, and they have Wi-Fi. You recharge them with a USB, and they're like $30, $40 for the cheap ones, and maybe $100 for the expensive ones. So it's a great value, and that's how we took these images. this is the right ear. It shows that this person has bilateral ear problems, has a perforation and discharge. And then the left ear, this is the cholesteatoma here. This is the pars flaccida, or the thin part of the eardrum. And it's been pulled in probably for years, and it's caused the bone to thin and this keratinaceous material to get stuck in a pocket. And even you can see it behind the tympanic membrane here in the middle ear. This is the incus, this is the stapes down going away from us. And this white area represents this material coming and diving in behind the tympanic membrane there. So this is clearly a cholesteatoma. And when people look in the ear, you always have to, you look in and then you look up, because most of the exciting problems are going to be either above the tympanic membrane or in the posterior superior quadrant like this. The eardrum is retracted. There's some inflammation. This is where the moisture comes from. This is called granulation tissue, this white stuff. And then here is the incus, and then the stapes down below. And here's the audiogram. So take it away, Amy.
So in this particular case, the left ear is the better ear than the right. The symbols are farther up on the graph than the right. In this case, both ears have a gap between the bone conduction response, which is straight to the inner ear, and the air conduction response when the sound had to go through the ear canal and the middle ear space. There's a greater, what we call conductive component in the right ear. The gap is greater than the left. The word recognition ability, again, is still very good, 92% and 96% in both ears. And when you look down at the tympanometry section, the tracings are not drawn in on this particular example, but if we look at the numbers in the box below, both ears have abnormal tympanometry. The left eardrum has no movement. The right eardrum has very little movement. In the acoustic reflex section, the left reflexes were absent at all test frequencies. And in the right ear, they were unable to test, could be due to lack of hermetic seal. But regardless, we have an abnormal finding on both of those that correlate with the conductive finding. Well, actually mixed hearing loss on the audiogram, because there's inner ear hearing loss in both ears. But in addition to the inner ear hearing loss, there's an additional middle ear component. So this would be considered a mixed hearing loss. It's a combination of inner ear and middle ear.
Okay. Do you want to briefly, because we're running short on time, just explain in very quick terms what this is?
This is the distortion product otoacoustic emissions. And what this does, it's a test that measures the response, the sensory response within the cochlea in each ear. There's a sound that's put in. If the cochlea is intact and the outer hair cells are intact, that sound will be reflected back by the hair cells and picked up by the equipment, and it will plot the response on the graph.
So the beauty of this, it confirms, right? The beauty here is it confirms in a completely objective way what you have measured in a subjective response. And the only other thing, because again, we're a little short on time, is that it's excellent, and it's how most centers are measuring newborn hearing. Isn't that right?
Correct. Because it is faster than doing the ABR, which is a lot of times done in hospitals. This is a very quick way of getting a response.
Yeah, so a newborn should have normal responses here. And if not, then they need to be referred on for further testing. Here's an example, again, of a CAT scan. This is that patient, and it shows the cholesteatomas. This is the right ear, and it shows that there is tremendous problems in the right ear, at least fluid and maybe a cholesteatoma. And then here in the left ear, you can see here's that ice cream cone, and this is cholesteatoma because there's bony destruction. extending into the mastoid. As you come through, you can see it in the middle ear space. And this is the ear that's getting my attention first. And you can actually see the other ear had a previous surgery and is having problems again. And that's one of the unfortunate things with ear diseases. A lot of times, if they've had cholesteatomas, they're at risk for them coming back. And you have to be vigilant because the underlying problem with cholesteatomas in most cases is not cured. It's the eustachian tube. And you can kind of see, here's the eustachian tube on the right ear, and it's very congested. So the problem is you're not getting air from the sinuses into the ear, and it's causing all these issues with the middle ear and the tympanic membrane, and it sets the stage, the chronic eustachian tube dysfunction, for the development of a cholesteatoma. Superior canal dehiscence is not a well-described outside of otologic circles problem, and it can drive patients a little bit crazy because there's all sorts of a variety of symptoms, including dizziness. This is the one surprising that seems to bother people the most, this oral fullness. You'll have patients often complaining of this. And don't immediately think that they have a middle ear infection or some kind of fluid, because there are many causes for this, and including sudden hearing loss, which is more of an emergency than the infection. And so don't diagnose infection just based on them saying my ear feels stuffy or full. Make sure you do a very good complete evaluation or refer them on if you're not sure, because infection in adults is actually pretty uncommon. But the superior canal dehiscence is a very interesting thing, and it's why I pointed out the CT scan, the superior canal. Amy, could you go over this for us?
Now, with this test, the test results are better in the right ear than the left ear. Both ears have what we call sensory neural hearing loss. It's an inner ear type of hearing loss. You have a low hearing loss in the lower pitches in the right ear. At 250, it dips down below normal, and loss at all frequencies in the left ear, the blue. The speech understanding ability, the word recognition, those scores are 100% in the right ear and 40% in the left, which is consistent with an inner ear type of issue versus the middle ear we were looking at before. The tympanometry section at the bottom, eardrum mobility is normal in both ears, and the acoustic reflexes are really consistent with the hearing loss, which is what we would expect with more of an inner ear type of issue.
So we've got kind of a mixed picture here, and I'm actually would be concerned about other things than just superior canal syndrome in this, wouldn't you, Amy?
Correct.
Yeah, so here's the otoacoustic emissions, and I'm gonna just kind of pass on by them and present the superior canals, because I think, unless Amy, did you have anything you wanted to mention on the emissions in superior canal syndrome?
No, go ahead.
Right. So anyway, in this, here's the coronal CT scan, and you can see the cochleas here. And then as we come back, you start to see here on the right side, this is the superior canal coming up directly towards the temporal lobe. And here you see it on the left side. And in most patients, there will be bone covering the superior canal and separating it. But in maybe 20, 30%, it will be absent. And in most of them, it doesn't seem to be a problem. But you can see here the canal, and there's really nothing between the canal and the gray brain above. And here you see it even better. This is dehiscent. And it's, as I said, most patients don't seem to be bothered much by it. And I don't really believe that the significant hearing loss in this ear, a portion of it, but I don't think most of it's being caused by this, even though it's being presented that way. Because you'll see patients with this, and that you could be anywhere from normal to a significant conductive hearing loss because of what we call the third window. Sound normally comes in with the stapes and then out through the round window, but this gives another avenue for vibrations to occur and loss of energy, and it will cause a cochlear conductive loss. And whenever I see conductive hearing loss and thinking stapedectomy, which is a surgical procedure for repairing conductive hearing loss, I always get a CAT scan to look for this, because if I see it, the surgery is likely not going to work. You can see as we get back further, now there's bone over it, but we always look for that. And there's a little bit of it on this other ear, on the right ear as well. I'll skip through the rest of this. And then the final, I think, no, there's two more cases. This is a petrous apex, chronic ear pain, and sometimes hearing loss, occasionally infection, but most not, can be a petrous apex cholesterol granuloma. This is primarily going to be a radiographic diagnosis. I don't think there are anything findings on audiogram that is pathognomonic of this, but we do have a combined sensory neural with conductive component, kind of a strange looking audiogram. Amy, would you comment on it?
Yeah, this particular audiogram is normal in the right ear, and in the left ear, it dips down in the mid frequencies and comes back up to normal hearing in the higher frequencies. The the word recognition ability is also good in both ears. Normal tympanometry, and the reflexes were normal in both ears when measured only ipsilaterally. They couldn't get the contralateral response, but this is a completely different configuration than the other cases that we have seen, as you can see.
It's an unusual picture, and I'm going to go right through the OAEs and show the scan. This image, as we come through, here is the cochlea, and this area right here is this large cyst that's out, and this is what we call the petrous apex, or the deepest part of the petrous bone, and this is eating away the bone. And it's a little hard to fully appreciate and understand how that might be affecting the cochlea, because there's a pretty good distance, but we do see it fairly commonly, and it may be causing inflammation of the nerve roots of the 7/8 nerve complex as it comes in here, even though there's really not much pressure. And in this patient, we also got a MRI scan to look at this area, but you can see it looks like a big egg sitting out here. This is the carotid artery, an important structure, of course, and that goes right through the ear. Carotid artery, if you're not aware, is right posterior to the eustachian tube. And so you do have to think about the carotid artery when doing procedures aimed at the eustachian tube. Well, here we've got this big goose egg sitting right in the middle of this person's skull. And we haven't done surgery. We may not do surgery because sometimes they can sit out here and be fairly benign. We're going to repeat a scan. She's coming back in 3 or 4 months from now, and we'll see if this is enlarging. If it's not, we may monitor the hearing and the size of this, because the surgical approach to something this deep can be tricky. Often we will try to go through the mastoid and work our way out this way, but it's a long haul. And interestingly, on this study, it might have an approach through the nose, because there's a very thin septum right here between the back of the nose and this cyst. So that might be another way of getting through it. And you can even see here where it almost looks like maybe it came from the nose. Most of these are otologic, but in this particular case, I thought maybe that this somehow had its origins extending out of the nasal cavity. And then our final, I believe our final presentation is an acoustic neuroma, which is a benign, always benign, fortunately, tumor that grows on the 7/8 nerve complex, typically off the vestibular branches. here we have a 68-year-old. It could be anybody. If you have asymmetric hearing loss in anything but an adolescent, and it's only in one ear, you have to think about acoustic neuroma. Hearing loss in one ear needs an MRI scan. Amy, why don't you describe this a little bit?
So in this particular case, the left ear is the better ear. The right ear has a significant hearing loss in the higher frequencies that is inner ear in nature. And the word recognition ability correlates with this. There's poorer word recognition scores. There's two tests here. The one on the left is from August of 2020, and the word recognition score is only at 60%, which is still not good, but still an asymmetry there. And if you look over to the test on the right from August of 2021, that score has deteriorated to 28%. So a significant decline over the course of 1 year. The hearing, although the hearing is stable from one test to the other, the word recognition score is much poorer. The tympanograms are both normal in both ears, and the word recognition ability, the acoustic reflexes are abnormal. The left ear is normal, the right ear is absent on both tests, and that would be because of the acoustic neuroma interacting with the auditory nerve in such a way that it obliterates that reflex. And the acoustic neuroma also interferes with the word recognition ability, depending on how it grows and how it impinges on the auditory nerve.
Right. And so here's an MRI, and as this is a T1 image, not a T2. And if you were paying attention, you'll see that although this is the acoustic neuroma, it's sitting in the cistern, the posterior fossa, cerebellopontine angle, which is fluid filled, it's spinal fluid, but because this is T1 instead of T2, it doesn't light up nearly as much. So this, you know right away looking at it, if the spinal fluid's not lighting up, that it's a T1. And then they give contrast, and that's why this enhances so dramatically. Fat also shows up these are the fat planes in the face and behind the eyes. And then you have this unmistakable acoustic neuroma, which is starting to push into the brainstem a little bit. So that explains the rapidly dropping word discrimination. This is a large acoustic, and it's causing compression on the nerves, on the blood supply. It extends deep into the internal auditory canal. Sometimes you'll see them actually growing in the cochlea itself. And I don't think I can scroll through this one, no. So anyway, that is what you need to be worried about with asymmetric hearing loss. The other thing is that you may have a treatable condition, and so you need to quickly evaluate with audiogram anybody who comes in with a drop in hearing and not assume that it's some kind of ear infection. We see that all the time, people getting antibiotics when what they really have is a sudden hearing loss. With that, Amy, do you have anything else that you would like to add to what we've said?
No.
Okay, well, thank you for attending. We will, in the presentation, the live presentation will be available for question and answers. And so keep those, and we will address them when we're live. Thank you very much.
Thank you very much. I look forward to your questions.
Hi, welcome to our presentation on the review of systems and charting in advanced practice providers perspective. My name is Caitlin Robertson. I'm an audiologist. I'm also here with Martha Botero Rovera and Hannah Spear, who are physician's assistants. And here's a little bit of our biographies. We all work together at ENT and Allergy Associates of Florida in different aspects. Our objectives for today's talk are to develop a systematic approach to interviewing and examining the ear, nose, and throat patients, understanding how to apply the knowledge of the ear's anatomy to conduct a more thorough and systematic review of systems, and to coordinate best patient outcomes between ENT practitioners and audiologists using the review of systems. As a disclosure, we have no conflicts of interest or any disclosures with the presented material in this presentation.
Good afternoon, my name is Martha. I'm a physician assistant. I work with Dr. Nathan Nathas at the Nose and Sinus Institute of Boca Raton. Why do we do a review of systems? The review of systems is an inventory of the body systems gathered through a series of questions to seek and identify signs or symptoms the patient might experience or has experienced related to the chief complaint. It serves as a guide to help identify potential or underlying illnesses and help lead us to focus physical exam. So we're going to do, when we do a review of systems, we do it in a systematic way with the ears, nose, and throat. First, we start with the constitutional signs and symptoms. All of those are important to kind of narrow what the patient might have. It can give us an idea of what is going on with the patient and narrow down that differential diagnosis. During the practice, you can, you're going to create your own way to do a review of systems. And then we start with the constitutional signs and symptoms. First, you can ask fever that's related with anything that is going on in the ears, nose, and throat. If a patient has an ear pain, that can narrow down to an ear infection. Nausea, so if the patient has any dizziness or vertigo, that can also guide you to what the patient might be having. Vomiting, headaches, weight changes, palpitations, even weight changes can affect the ear, nose, and throat. And now going to the ears. You can ask, when you ask the review of systems, you should ask in a very natural way, or rather just a simple questions and something that the patient can understand. For ringing, you're not going to ask the patient, what do you have any tinnitus? You just say, do you have any ringing of your ears or any weird noises in your ears? Any hearing loss, or does the sound bother you? Is it too loud? Is it too low? Any itching in your ears? Any discharge? Any is it anything coming out of your ears like a discharge? Any pressure of your ears? It's like the feeling of you going into a plane. It's kind of try to guide the patient of what they are feeling. For vertigo and dizziness, you should be precise on the questions you're asking. Is the feeling that you're having any room spinning? Is the lightheadedness? Is like the feeling of passing out, or it's just imbalance that you cannot stand on your feet? For ear pain, you can ask the patient, is it both ears, is one ear? What kind of pain? What type of pain? Is it throbbing? Is it sharp pain? And again, any fullness in your ears, is it pressure? What type of fullness? And again, if it's in the both ears or one ear. Now in the nose, And you can ask questions as any nasal obstruction is the feeling that nothing is coming out of your nose is in both nostrils, in one side, it alternates. Any sense of smell changes. It's a burning type of smell, because that can narrow down to something going on in the brain as well, like infections, any congestion of the nose, discharge, anything. If you have a discharge, what color? Is it green? Is it clean? Is it yellow? What kind of discharge? Any nose pain? And if so, is it now? Is it acute? Is it chronic? How long have you had it? And where in the nose? Is it dorsum of the nose and tip of the nose? Where is the pain? For nose bleeding, that you can ask the questions, it's in one nose, one side of the nose, is it both sides of the nose? Do you have any other bleedings in your body, in your mouth, any other sides that are bleeding? Any postnasal drip. Most of the patients don't even know what a postnasal drip is. So you just ask them, do you have the feeling of something running behind your throat that is making you clear your throat? And snoring, is that something that your partner notice? Is it a loud noise, or it's not snoring, or is something that bothers you and your family? Now going to the throat, mouth, and sinuses. You started asking, do you have a sore throat? Is it in both sides of your throat? Is what type of pain you have? Is it painful? Is it sore? Is it the whole throat, one side or the other? And if difficulty swallowing, if you have any difficulty swallowing, is it with liquids, solid, or with both? And in what part? Is it just when you are, as soon as you start eating, or just going down? Any hoarseness or any voice changes? Is it a hoarse voice? Is it a raspy voice? What type of voice? For neck tenderness, do you have, is all the neck tender, or is where in the neck is your tenderness? What type of pain? Any throat clearing? Swollen glands, where are your swollen glands? Is in the back of the neck, in the front, behind your ears, below your neck? Where are the swollen glands? Again, for voice changes, we discussed already. Any lumps in the throat, where is the lump? Do you feel something stuck in your throat that you cannot clear or spit out? What, how long also? Any headaches, that points to sinus headaches, or maybe a deviated septum, something that is causing all those headaches. And facial pain or pressure, that also tells you a lot about what's going on with the patient.
Thank you, Martha. So I'm going to start by linking the 5 major categories of ear symptoms to the anatomy of the ear, and discuss how we can use our knowledge of anatomy to connect symptoms and groups of symptoms with the anatomic location that's likely responsible for the underlying disorder. So this is just a brief overview of the ear anatomy. So we have the outer ear with the external auditory canal, and it's separated by the tympanic membrane from the middle ear. So we have the middle ear, which includes the 3 middle ear bones. And then finally, the inner ear, which holds the semicircular canals, the cochlea, and the nerves. So from this slide, what I think is important is that by envisioning the anatomy, we can really ask our relevant questions in a systematic way. We can start from the outer ear and move to the inner ear, asking questions that are relevant, or vice versa. And this approach may help organize your thoughts and your questions. The review of systems is a dynamic process where you use the 5 major categories alone or in conjunction with each other to start narrowing down your differential diagnosis. So first, I'll discuss hearing loss. When a patient reports hearing loss, we're really thinking about the entire ear, the outer, the middle, and the inner, because hearing loss can be caused by problems in all 3 parts. So we know that there's either conductive, sensory neural, or mixed hearing loss, but we really need to ask the right questions to help localize where the problem in the ear is that may be contributing or causing this loss. So for the outer ear, we're really focusing on a conductive loss, and we're thinking about disorders of both the external ear and the ear canal. Our minds should really already be thinking possible cerumen impaction to otitis externa to tumors of the external ear. For the middle ear, we're focusing on a conductive loss as well, and we're thinking about disorders that involve the 3 middle ear bones. And we should be thinking maybe about a serous otitis media, to ossicular trauma, to otosclerosis, or possibly a cholesteatoma. And for the inner ear, we're focusing on sensory neural hearing loss. And we're thinking about disorders, for example, that may be affecting the cochlear nerve. Moving on to the next two symptoms, tinnitus and vertigo. These are both generally inner ear symptoms. So when a patient responds yes, when questioned about ringing or vertigo, we should really focus our attention to the inner ear structures. So true vertigo is described as a spinning sensation, and it's important that we differentiate this true vertigo from disequilibrium, which is the generalized feeling of just being off balance. Spinning may be the result of abnormalities of the semicircular canals. And tinnitus is any abnormal noise in the ears. It's a really broad definition, which makes it hard to pinpoint a cause. But if it's subjective tinnitus, it's typically related to the cochlea or the cochlear nerve, but this is really not totally understood. Next, we'll discuss otalgia or ear pain. It's often one of the most troubling symptoms for the patient. What I want to drive home on this slide is the importance of trying to ask questions that will help differentiate otogenic pain from referred ear pain. Otogenic pain is true ear pain. It may be secondary to inflammation or infection in the external or the middle ear, or it may be associated with complaints of hearing loss or disequilibrium. And the source of this pain is usually obvious on a physical exam. Referred ear pain, on the other hand, is pain that the patient's experiencing in the ear, even though the source is located in a different anatomic region. So for example, we can talk about TMJ, because TMJ can cause referred pain to the ear, or even inflammation along the course of the ninth cranial nerve can cause referred pain. So something like tonsillitis, tumors in the pharynx, the hypopharynx, or the nasopharynx can all cause referred ear pain. And lastly, I want to discuss otorrhea or discharge from the ear. When a patient reports ear discharge or drainage, we're really starting to think more external or middle ear related issues. Specifically, it could indicate an external otitis or a draining middle ear from a ruptured tympanic membrane, or a chronic suppurative otitis media, to name a few. So what's important here is that we want to ask the patient really close follow-up questions regarding the drainage, because this can actually give us good clues into the composition and the origin of the drainage. And something to keep in mind also is that some patients may confuse discharge just with wet cerumen that's draining from the ear. So you want to ask, like, is the drainage different than what you're normally experiencing, or is it not really changed much? And then some combining a couple symptoms such as otorrhea and otalgia, this could indicate an otitis externa, for example, or maybe severe otalgia that resolves when the otorrhea starts. This could indicate maybe an acute otitis media that's ruptured. So as an overview from my part, I just want to talk about how performing an ROS is a dynamic process. It really gives you a constantly evolving understanding of the patient's complaint. But by linking our knowledge of the ear anatomy to specific symptoms or groups of symptoms, we may be able to better understand the location of the underlying disorder.
Thank you, Hannah. So again, I'm Caitlin Robertson. I'm the audiologist, and as a final portion, I'm going to start to tie in how the review of systems works in audiology. Our role as audiologists is to really help physicians diagnose and to come up with a treatment plan for our patients by identifying hearing loss and other ear-related dysfunctions such as balance disorders. Most of your clinics will have a basic case history protocol related to hearing imbalance. Common questions like, when did the hearing loss start? Which ear? Are you having ringing? All of those questions that are really ear focused. But I want you to consider asking more involved questions, such as a history of diabetes. Is it type 1, type 2, controlled, uncontrolled? Do you have high blood pressure? Are you on medication? As all of these things that you may not think directly relate to hearing can actually really influence hearing outcomes or balance conditions. The patient's health status may influence other tests that would need ordered for the patient. They can affect the selection of amplification or even influence referrals to other healthcare providers. It's so helpful to compare the review of systems and all the notes from other providers, especially like their primary care or the other ENTs, and look for overlap or additional information that you may not have gotten. Working together as a team to make strong recommendations is really going to be the best thing for the patient, especially if you're seeing them as a whole and determine that they need some of their specialties. So yes, the review of systems does have a high overlap between audiology and ENT. We ask a lot of the same questions. We look at each other's notes and our case histories because patients do often tend to tell us different parts of the stories. As you know, our visits can be really short on each side. So you might get a different story or a different explanation of a symptom at one visit with the physician versus what you get as an audiologist in our short hearing test times. If a patient comes in with a specific complaint, such as oral fullness or feeling like their ears are clogged, you'll want to know if the ENT was seeing something like sinus dysfunction. On the flip side, the ENT or ENT practitioner will want to know if there is evidence of a middle ear disorder, conductive hearing loss, or eustachian tube dysfunction within our testing. And I also want to know if there's something different, such as a different type of hearing loss that could be causing their symptoms. So the ENT may go into more depth in some aspects due to the nature of their exams as part of their patient assessments, but audiology will really focus more on just the ear specific pathologies. However, it is really important to think of the patient as a whole. Another example of this is something that's coming more on the forefront during hearing evaluations and screening for cognitive decline. For example, a patient may present with presbycusis or age-related hearing loss, and they may show decreased word understanding on a hearing test. They may have poor performance in their hearing and noise testing, and you may do a cognitive screening tool such as the mini mental, which will show that they're at risk for cognitive decline. So then you would think as a whole that, okay, this patient needs some hearing aids, but it would also possibly trigger referrals to help get them care for the possible deficits in their cognitive function that could be dementia or Alzheimer's. And ultimately treating the patient as a whole in that way is really going to give them the best outcomes. So having a complete review of systems will help physicians make appropriate decisions in order to diagnose and treat the patient in the most effective manner. How does the review of systems relate to reimbursement? I think this is particularly important in audiology since we're performing a lot of the diagnostic testing and you really have to have a strong reason for performing tests. So you have to be very clear. You have to really plainly state the chief complaint. And you have to make sure that you're documenting this in all of your testing and all of your reports. Some other things to consider is that oftentimes there are physician quality reporting factors that might be included in your review of systems that you would not think of. They can give extra incentives, sometimes higher reimbursement rates for practices or hospitals. For example, a few years back, audiology did have to screen for tobacco use and fall risk in order to meet updated guidelines and to receive the highest level of reimbursement. But just in general, those are great things to be asking patients because you do want to understand what their risk factors are for hearing loss, balance problems on things that are not directly related. Any questions? Thank you guys so much for listening to our presentation.
Good afternoon and welcome to the session Medicare Expansion and OTC Expectations and Impact on Hearing Care. My name is Dr. Tom Powers and I will be with you for the next 20-30 minutes talking about these two topics. So with that, maybe we'll get started here a little bit. In terms of background, I'm currently the managing member of Powers Consulting, a management company providing resources to the hearing health industry. My background is in audiology from State University of New York, Geneseo, and my master's and PhD in audiology from Ohio University. Started off in a private practice in Huntington, West Virginia, and then after several years moved into the hearing aid industry where I spent the bulk of my career working in a variety of capacities. With that introduction, we could read the rest and spend a whole lot of time there. My disclosures are obviously I'm working in my own consulting company. I am a strategic consultant for the Hearing Industries Association and a limited partner in Remote Ear, which is a telehealth company. Today, we're going to talk about Medicare expansion, a little on OTC, and then summarize where I think the impacts are these two will be on the hearing healthcare as it goes forward. So why is the focus on hearing healthcare now? What's causing some of this expanded interest, if you will, in hearing healthcare? I think the changing demographics that we see here with the aging population and the intersection of hearing loss within that group is driving this. The estimates are that in the not too distant future, we will have a group over 65, primarily the boomers, but over 65 be a larger group than those under 18 for one of the first times in our country's history. And the recognition that hearing loss is a public health priority and societal responsibility. We see a tremendous amount of literature in terms of how the comorbidities with hearing loss, diabetes, cardiac health, dementia, and Alzheimer's are playing a role. I think this led to some of the workshops and meetings that were held, starting with NIH meeting, I think in 2009, moving into 15 and 16, 17, with meetings being held by the Institute of Medicine, which became the NASM, National Academy of Science, Engineering, and Medicine. Also the FTC, the FDA, and PSAP, which was the President's Counselors, Advisors on Technology and Science and Technology. All of that drove a tremendous amount of interest and led up to the legislation for OTC devices. We have a lot of changing technologies in the hearing aid business, if you will. Also changes in overall healthcare, but also in hearing healthcare in terms of the products and services and how they're being delivered. And we'll talk more about that when we talk maybe about OTC, but we're seeing a much greater online presence and telehealth being used in the delivery of hearing healthcare. In regards to Medicaid expansion, as we all know, the original Medicare excluded hearing, dental, vision from coverage. Back at that time, potentially, I guess they were viewed more as wellness as opposed to health related issues. There is some coverage available currently for diagnostic hearing and balance exams and diagnostics and cochlear implementation for those individuals who meet the criteria. This does not extend to hearing evaluations for the purpose of obtaining a hearing aid or hearing aids or related services. So those are excluded. And only the diagnostic side. Medicare Advantage, on the other hand, does provide access to a hearing benefit. We'll talk more about that in a little bit. Original Medicare, as we all know, has two programs: a fee-for-service health plan that has two parts: the hospital insurance in Part A and medical doctor insurance in Part B. Hearing aids are not covered, as we already mentioned. However, Medicare Advantage does provide a benefit for the vast majority of patients who are currently enrolled in Medicare Advantage programs, which include vision, dental, hearing, chiropractor, health clubs, and other services that are very attractive to members. And that's the purpose of including those, is to have them join that and become a member and expand the Medicare Advantage plan that offers those services. It is Medicare in the private sector. Again, we all know. As of June 2020, about 40% of total Medicare beneficiaries are enrolled in Medicare Advantage. This is a number that's growing and continues to grow. in the Medicare Advantage plans due to the fact that they're offering, again, services and benefits that are attractive. Expected to grow to over 50% of the Medicare population by 2030. The Kaiser Foundation, Family Foundation, found that almost 80% of enrollees in these Advantage programs have some type of vision coverage. 74% have dental and 72 have hearing aid or hearing aid exam coverage. So we see a very high percentage of people who are in these programs. Again, 40 to 50% of total Medicare beneficiaries have these vision, dental, and hearing coverage. The utilization is maybe not what we expect, but the coverage exists. And I think as more people move into these plans, I think we may have thought that these would be where the expansion would take place. But we now know that this is going to take place under traditional Medicare. The reconciliation process, again, we've all been following, so we don't need to spend a lot of time, but this starts off with a budget resolution, goes to the committees within Congress, the committees report back to the main House with changes that they've made within the committee structure to the bill. The total reconciliation bill is considered. Any differences between the House and the Senate are resolved, and then potentially, if it all goes well, which we've seen may not be happening right away, the bill is enacted into law or vetoed by the president. So this is a pretty cumbersome, but is the process that is in Congress for doing this reconciliation, and we'll see where this ends up. Right now, some of the priorities that the hearing healthcare community is looking toward, and I think many have been talking to their members of Congress about how this should and they'd like to see work. So these are the priorities from I'll call the hearing health industry, as well as the audiological and professional and consumer groups. That the device should be a prosthetic classification, not durable medical equipment. If it is classified as prosthetic, that exempts the hearing aids and services from the competitive bidding framework, which I think would become very cumbersome in terms of how hearing health is delivered. So right now, that would be a priority, and it appears that that's the way it's going to work. Beneficiary choice is another recommendation from the groups, and that is to have what's called a top-up provision. Would allow the beneficiary to choose a more expensive device and pay the difference if they would like. This exists in some programs. Australia, for example, has a top-up where you can pay the difference between the entry and the middle level or top level device. Access would come down to authorizing all licensed hearing care professionals to provide Medicare covered services. Currently, that's not the case in one of the bills. But again, the recommendation is to have everyone included so that access doesn't become an issue for someone who's maybe in a potentially more rural or not in a city environment where there may be more professionals to provide those services. So in the U.S. House, the text currently of the bill, and again, this recording is being made in early October, so by the time we get to our meeting, things could change. But right now, they are classified as prosthetic devices. They are exempt from competitive bidding when furnished to the physician or practitioner's office as a part of their service. And so that's an important part, is that they need to go through the professional, not through some external entity. Hearing aids would be covered once every 5 years, so the patient could get new devices. Severe to profound hearing loss only at this time, and OTC is excluded. Obviously, we don't really have OTC devices in terms of the guidelines. We expect them soon. But right now, it is only for severe to profound hearing loss. As it exists in the House bill, audiologists and certain practitioners, primarily physicians, would be able to receive payments, and that bill does not include hearing aid specialists as a provider of these services. As mentioned, that is a recommendation from the groups within the hearing health community. Senate, as of today, or 2 days ago, it doesn't have any specific language. There is support, primarily led by Senator Sanders, for speedier access to benefits. Here you see the phase-in. That's a proposal right now for vision to be phased in 2022, hearing in 2023, and dental not till 2028. They would like to see potentially speedier access by providing potential debit cards while this is being implemented. Manchin and Cinema, obviously, two senators that are critical, and we've been hearing a lot from them recently, remain pivotal in whether or not this might take place and actually pass and get done. So this is pretty comparative to previous legislation. That was HR 3 from the previous Congress, again, classifying hearing aids as prosthetics. While the current bill only includes audiologists, HIA, audiology associations are trying to work to get licensed hearing aid professionals, anybody within the scope of practice today, into the Senate language. Audiology is certainly working on the Medicare Access and Services Act, or MASA, to reclassify audiologists as practitioners and eliminate the need for a physician order for coverage. These are all things to streamline the access part, and obviously the coverage is to deal with some of the affordability issues that may be put up in terms of getting hearing aids today. The CBO, or the Congressional Budget Office, scores costs for all things that Congress is considering to spend money on. It fixed a 10-year program for the previous bill, which was HR 4618, at approximately $30 billion over a 10-year period for vision, about $89 billion for hearing, and $238 billion for dental care, which I think leads us to why the implementation phase-in periods were established to phase in potentially the lesser cost options for vision and hearing before dental. But again, that remains to be seen if that's going to happen. I think one thing we should note that even if this does happen, the implementation could take some time. When the Part D Medicare was implemented in terms of prescription, from implementation to when it actually became effective was about a 3 to 4 year period to get that moving and implemented. So this may take some time as well. So that's where we are on the Medicare expansion, and we may have more to discuss in the question and answer period next month when we get together for the meeting. In terms of over-the-counter hearing aids, we now know that the rule was included in the spring agenda from the FDA, and that OMB has issued at least some recommendations to the White House, and we believe that that has now moved back to the FDA, and we could expect very shortly, maybe still in October here as we're recording this, to see those draft regulations. President Biden did issue his executive order asking them to speed up the process and to get this done in the next 120 days from when his executive order was issued. So we would expect that sometime here in October or November, there would be a publishing of those rules in the Federal Register. There is a 60-day comment period for all stakeholders and everybody to comment. The FDA then has 180 days to respond to those comments and or change anything in those rules. At that point, they would issue the final rules together with, obviously, their comments back to those people who submitted comments. And generally, 30 days after that is published in the Federal Register, those rules go into effect. So as you can see from the timeline that's anticipated there, that expects us to have the full release and devices under the OTC labeling available sometime next summer. We'll see if that holds true, but we think that's a reasonable timeline at this point. Because this has been delayed, obviously well over 3 years and close to 4 now, this new channel, the DTC or direct-to-consumer channel, has evolved. The FDA has said that it is different than OTC. We do have the first direct-to-consumer device that's been approved, which is the Bose device, which was approved as a self-fit direct-to-consumer hearing device. However, we do have a couple of other systems for delivering hearing healthcare that have evolved. And these involve either having a professional involved at some level or none. A number of companies are involved here, and I'm not going to go into each of their offerings, but we have some that you buy the device online, and there's either an app potentially or instructions on how to use it, how to get in your ear, etc. Some do have a professional involved, and that could be either a customer service, person, somebody who's trained, could be a hearing professional, whether an audiologist or a dispenser, who provides help via either a chat or an online chat or phone call. And then some do have professionals involved, Lively being the probably best example many of you may know, where the hearing test is done online, the device is pre-programmed, the device is sent to the user, the consumer, and then a session is set up for that professional to help that person with the fitting. And typically those professionals are licensed in the state where the consumer is actually located. So while the professional may be somewhere else, they are under the Lively model licensed in that state to provide those telehealth services. And others have similar models as you see there with a number of different companies. So DTC, my expectation is, will morph into the OTC regulations, and all of those devices will need to be either registered, 510K, whatever these guidelines turn out to be when we see them in the next few weeks. I think another agency that we need to take a look at here will be the FTC. The Federal Trade Commission has jurisdiction on false and deceptive advertising. In terms of how this works within the two agencies, they have a memo of understanding that FDA is primarily involved in the labeling, safety and efficacy, and the FTC primarily has jurisdiction over the advertising. And they have issued some letters and warnings and fines to people that have made unsubstantiated claims about their devices. And again, even if it's true, it's deceptive if you don't have substantiation for the claim. So the FTC has pretty broad reach. They were also the agency that issued what's now been referred to as the eyeglass and contact lens ruling a number of years ago in vision, where you receive a copy of your vision test results prior to any discussions about whether you will purchase your vision services and products at the place where you got the testing. Then you could use those test results to order online, either for eyeglasses and or through the various sites that offer contact lenses. So unbundling, I think, is another issue that we're going to have to begin to think about how this will work in practices that are providing hearing healthcare. And one or more of the things are probably going to happen, and that is the FTC, as we just mentioned, could, once the FDA guidelines are out and we move forward, could issue guidelines very similar to what they did in vision, that you go and get a hearing test, and once you have the results, then you can make a decision about where you purchase services and products. OTC pricing will, I think, have an impact, and that is those devices are going to be sold as device only with no professional services. So you see the unbundling taking place there. Some of the online models do include services, but I think as patients begin to see the cost of the OTC devices, we already have somewhat of a benchmark with the Bose device at $849 for 2 devices. So if that holds true, we expect the devices to be in the $300 to $400 or $500 range per device. Consumer demand, when they come into the office, they may expect that the device, whether that's OTC or traditional hearing aid, is separated from the professional services. And again, Medicare expansion, because it is a fee-for-service model, is not an unbundled. It's an unbundled, if you will, model, and not a bundled model. So that may also have an impact on how this plays out. Although it will start for severe to profound losses, it may have an impact across the entire pricing structure for hearing aids within hearing health. So I see there will be probably still a single fee model in the private market for those that are outside any insurance, whether that's Medicare, private insurance, or anywhere else. The OTC products are a little bit different, but also an unbundled fee for service and products for patients who may have either an OTC or a traditional device. The product pricing would be separate, and then services, whether that's short-term or long-term, may be separated out the way they were when I first was in private practice back way in the late 70s and early 80s, when everything was unbundled due to the ASHA ethical considerations, where audiologists were not allowed to profit from the sale of hearing aids. And so every service was itemized: the hearing test, hearing aid evaluation, ear mold impression fees, etc. And so follow-up services, whether you're a new or existing patient could be very different. If it's your second or third set of devices, you probably know a fair amount about how to use the device, get it in your ear, where to go and sit when you are in a meeting with background noise. New users may need a bit more attention, and so they may need more follow-up services. And how those are priced and structured, I think, is something we need to be thinking about, so we're ready that as this potential new pricing structure comes into play, we see how it will work for each and individual practice, because they're all going to be very different. What is the impact of all of these, if you will, on dispensing offices? I think consumers will expect coverage regardless of hearing loss. They may hear the Medicare expansion happens, they'll hear about OTC, the advertising is going to start, and they may decide that they like a professional opinion on what's going to happen and think that they have coverage. So we'll need to have materials or dialogue ready to explain what their hearing loss is if they have a hearing test, or that they should certainly get a hearing test first to decide where their hearing loss lies, but to make sure we explain how that works. Many consumers may expect that OTC devices will be dispensed through your practice. I've been referring to these as OTC devices because I don't know what they're going to be called, but if they're referred to as OTC hearing aids, then in the consumer's mind, a hearing aid is a hearing aid. And so they may not be able to differentiate those and think that they only can buy them online, that they will be available through your practice. And I know that's a discussion that each practice is going to have within the practice. Are we going to select a few OTC devices and have them available for patients who may want them? And then how will those be dispensed? What services come along with them, and how will they be priced? Or they may make the decision that that's not something that's going to happen. And I think that's a debate that has to happen within each practice. However, once the decision is made, if you do have OTC devices, how you triage those patients through the practice, and how much time is spent with them, how much billing goes to that particular practice, and that patient, I should say, is going to be important. The structure and how much time is set aside for an OTC versus a traditional hearing aid patient could be significant, from a half an hour to an hour and a half appointment. And the scheduling structure within the practice is going to have to leave time slots for each of those types of patient. I think the other issue is, how do we decide when someone comes in and starts asking questions, what are they a candidate for, and how are we going to assess that? Certainly the hearing loss is one of the first things, and we would encourage everybody to get a hearing test first to find out whether or not you have a mild hearing loss, moderate hearing loss. As we know, self-perceived hearing loss is usually milder than the actual hearing loss. Many people believe their hearing loss is not nearly as bad as it might be from having a hearing test. But we also need to find out how well they're doing in the environments where they feel they are having difficulty. Many early users, mild to moderate hearing loss, are situational wearers. They wear them potentially only when they are in background noise, in a meeting, in a restaurant, when family gatherings, etc., because they feel and probably might do okay in quiet environments. So how do we do that in a practice? Do we use the hearing test combined with hearing and noise tests, some questionnaires, hearing health, handicap inventory, etc.? How are those patients evaluated, and how are they counseled in regards to what type of device would best suit their needs? I think we have always looked at entry level, medium level, and high level devices. I think we may need a fourth category, and that is the OTC devices at the lower end for the mild to moderate, and or those people that are even on the cusp of normal hearing. I mean, we have a number of individuals who have fairly normal hearing with what we refer to now as hidden hearing loss, that are having tremendous difficulties in background noise. Are those people considered to have normal hearing, or are they considered to have mild hearing loss, even though audiometrically they're under 25 dB? They have significant issues in background noise, and those patients may be some of the patients where an OTC device could provide them some help, and especially in situations where they find themselves having difficulty understanding. I think also the last point here is consumers will seek transparency. pricing of products and services. We talked about this a bit earlier. As more and more advertising is going to take place, more marketing is going to take place for the OTC devices, which will be separated for the most part from the service component and the product. That overall transparency of what devices cost will be something consumers are going to know, and they may ask, how do you separate those products? What am I paying for? Medicare expansion is going to have the impact on that, and those patients that are in the severe to profound category, being more a fee for service model. We don't know yet how that's going to be structured, but potentially each service would be separated. So the hearing test would be, the hearing evaluation, the fitting would be a separate billing code. Follow-up services would have special and separate billing codes, as well as oral rehab and other treatments post-fitting. So how this works, we still don't know, but I think it's something we need to be thinking about in terms of how both OTC and Medicare are going to impact all of these things. Consumers are going to be coming, asking questions for us, and I think we all need to be prepared on how to explain how our practice works, what services we have, what products we offer, so that we can do the best that we can for each and every consumer and every patient who walks into our office. So with that, I'm going to say thank you for your attention. Thank you for being here, and I think we'll be moving to a question and answer. So again, thanks again, and have a good rest of the day.